Hello, my name is Missy Jackson, and the instrument I have chosen to present is the PHQ-9. PHQ stands for Patient Health Questionnaire, and the 9 is the number of questions involved in the survey. You have likely heard of this instrument as it is widely used for the screening of depression in many settings. In my practice setting, which is a large college health facility, this is the instrument we use to screen for depression and to monitor the progress of our students who are diagnosed with depression. To talk about the PHQ-9, we must first talk about the Patient Health Questionnaire, which was developed in the mid-90s by researchers at Columbia University. The Patient Health Questionnaire is a 59-item self-administered screening tool that evaluates for 12 mental and emotional health disorders. It contains several modules to screen for mood, anxiety, alcohol, eating, and somatoform disorders. Because of the length of the questionnaire, the researchers, with a grant from Pfizer, developed the PHQ-9 in 1999, and it was first published in 2001. The full Patient Health Questionnaire and the PHQ-9 are part of Pfizer's suite of trademarked products called Primary Care Evaluation of Mental Disorders, or PRIME-D. This was born from an effort to develop screening tools that could be used in the diagnosis of common mental health disorders. While Pfizer owns the copyright for the PHQ and the PHQ-9, they allow it to be used for free. The tool is currently available in over 70 languages. The PHQ-9 is designed to be self-administered by patients 18 years of age and up. It takes about 3 minutes to complete the survey, and it's widely used in primary care, obstetrics, and also in research. While it can be administered by paper and pencil, many organizations have embedded it into their patient portal and have patients complete it there. Or they may offer them an iPad or other device to complete the questionnaire in the office. In my organization, when a patient checks in for their appointment, the questionnaire is automatically pushed to their patient portal, and we ask them to log onto their phones and complete the questionnaire. While most of our students have cell phones, we do have iPads for those who are unable to access the patient portal on their phones. All of the questions on the PHQ-9 correspond to the DSM-5 criteria for depression symptoms, which include a depressed mood, diminished interest or pleasure in doing things, insomnia or sleeping a lot, significant weight loss or weight gain, people commenting to them that maybe they move slower or they are fidgety, fatigue or loss of energy, feelings of worthlessness or guilt, the diminished ability to think, concentrate, or make decisions, and thoughts of death or suicide. For a diagnosis of depression according to the DSM-5 criteria, at least one of the bolded symptoms must be present. In addition, the symptoms should be causing problems with the patient's social, occupational, or other functioning. And finally, the symptoms cannot be related to another mental health diagnosis. I suspect you have probably heard of both the PHQ-9 and the PHQ-2. The PHQ-2 is a shortened version of the PHQ-9 and contains the first 2 questions of the PHQ-9 and takes less than 1 minute to complete. Each question asks the patient to answer based on the previous 2 weeks, and they have 4 choices for a response: not at all, several days, more than half the days, or nearly every day. Based on their answer, the question is assigned points. So not at all is 0 points, several days is 1 point, more than half the days is 2 points, and nearly every day is 3 points. The first 2 questions ask, in the past 2 weeks, how often have you been bothered by the following? A little interest or pleasure in doing things and feeling down, depressed, or hopeless. Some organizations will use the 2-question screener, and if the patient scores 3 or more, then they will ask the additional 7 questions that make up the PHQ-9. These are the remaining 7 questions. Trouble falling asleep or staying asleep, or sleeping too much? feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself, that you are a failure or have let yourself or your family down, difficulty concentrating, moving or speaking slowly, or being fidgety or restless, thoughts that you would be better off dead or hurting yourself. And they answer those questions, all of them, as not at all, several days, more than half the days, or nearly every day. And just as a reminder, the questions that are on the PHQ-9 correspond to the DSM-5 criteria. With 9 questions, there is a possible score of 0 to 27. Let's take a look at the scoring criteria and interpretation. On this slide, you can see the scoring criteria and interpretation for the PHQ-9. A score of 1 to 4 indicates mild depression, 5 to 9 minimal depression, 10 to 14 moderate depression, 15 to 19 moderately severe depression, and 20 to 27 severe depression. The Cronbach's alpha coefficient is the most commonly used measure of internal reliability for scales with multiple items. The alpha score ranges from 0 to 1, with 1 indicating perfect reliability and 0 indicating no reliability. When the developers of the PHQ-9 developed the scale, it was found to have a Cronbach alpha of 0.89 for primary care. And then they looked at another study with obstetrical patients, and it was calculated a bit lower at 0.86. Each of these studies had roughly 3,000 participants. You may recall from our readings the levels of reliability based on the Cronbach's alpha. And as you can see, both studies demonstrated that the PHQ-9 has good reliability and almost crosses the threshold to be considered excellent reliability. In that same study, the kappa statistic was calculated after participants took the survey and then repeated it in 48 hours. The kappa statistic, or sometimes called the kappa coefficient, is the most commonly used statistic to determine intra-observer agreement. A kappa of 1 indicates perfect agreement, and a kappa of 0 indicates agreement only to chance. In this case, the kappa coefficient was 0.84, which indicates almost perfect agreement. To look at validity, I chose a recent study that evaluated the concurrent validity between the PHQ-2, the PHQ-9, the WHO-5, which is the Well-Being Index, and the BDI-13, which stands for the Beck Depression Inventory, which is another common scale for measuring depressive symptoms. As you recall, the Pearson R is always between -1 and +1, where a value of 0 indicates no relationship between the two variables. The closer the value is to 1 or -1, the stronger correlation. A positive value means that one variable increases while the other increases as well. A negative value means that one variable increases and the other one tends to decrease. Looking at the Pearson R value for the comparison of the PHQ-9 and the BDI-13, there is a positive correlation, and the R value is 0.60, which indicates a strong correlation. As I've pointed out before, the PHQ-9 is frequently used in primary care, obstetrics, and research to screen for depression and to monitor progress of depression. Because of its briefness, it is widely used. There are other depression screening tools that are used, but as you can see, they are much longer and require more time. And given the fact that the reliability and the validity of the PHQ-9 is so good, it makes an excellent choice for primary care and obstetric populations. The PHQ-9 is endorsed by the National Institute for Health and Clinical Excellence and healthcare organizations including the Veterans Administration, the Department of Defense, and Kaiser have adopted the PHQ-9 as their standard tool for depression screening. Hopefully I'm not the only person in this situation, but I have not yet decided 100% what my project will be. But I do know that I'm going to focus on depression in college students, which is at an all-time high, with rates having more than doubled in the past 10 years. Depression in college students has a significant impact on their academic success and quality of life. I began the program thinking that I would like to evaluate how implementing quality measures in our collaborative care program improve primary care provider and behavioral health care managers' satisfaction with collaborative care. However, because I felt the need to go ahead and implement those measures at my practice site, I think that one is off the table. Since writing a paper for the epidemiology course, I have began exploring other options, including introducing exercise as medicine as an intervention or implementing a sleep hygiene educational intervention for students with complaints of both insomnia and depression and/or anxiety. No matter what project I choose, there will need to be a measure, and since I am focusing on depression in some way, I believe the PHQ-9 is an ideal choice. First, it is a brief tool that takes about 3 minutes to complete, which will be a satisfier for college students. Second, it is the existing tool that we use at my project site. In summary, I would just like to point out the usefulness of the survey. It's widely used and validated. It serves as a screening tool that is aligned with the DSM-5 criteria for the diagnosis of depression. It's quick and easy. It's effective for monitoring treatment. It's a self-report format, minimizing clinician involvement and increasing the patient's autonomy. And it's applicable for diverse populations. It's also cost-effective in that it is free from Pfizer. Here are the references that I used for my presentation. Thank you for listening, and have a great rest of the semester.